you're safe. So never be that person that says, I would take them to theatre, because you won't in real life. Okay, so here's my answer. I'll read it out for you. So I would manage this patient using CRISP protocol and an A to E approach. Firstly, I would check the patient's airway and then move on to breathing. I would apply 15 litres of oxygen via a non-rebreather and then check saturations and respiratory rate. I would expose the patient's chest, check the trachea was central, and then percuss and auscultate the chest. Once I was happy with breathing, I would move on to circulation. Firstly, I would check the cap refill centrally and distally and assess the rate and rhythm of their radial pulse. I would put 2 wide-bore cannula into each antecubital fossa, take routine bloods, gas and blood cultures, and check the patient's BP and heart rate. If they were hypertensive, I'd give them a bolus of crystalloid fluid. I'd listen to heart sounds, check the JVP and get a 12-lead ECG, and I'd also like to catheterise the patient. I always used to forget that bit. Then moving on to D&E, I would assess GCS, pupils, blood sugar and get an up-to-date temperature. I would then expose the patient's abdomen for examination and assess the wounds for any signs of erythema or discharge. So that's my A to E. At this point, I'd be concerned about a post-op sepsis. Sources of this could be wound, chest, urine, intra-abdominal collection or line infection. I would therefore like to initiate sepsis 6 and prescribe some broad spectrum antibiotics, fluids and O2 and get a lactate cultures and urine output. Further investigations would include a chest X-ray and urine dip. I'd also like to look at the patient's OBS throughout the day and check their notes, in particular the OP note. So some people wouldn't say the last three paragraphs. Some people would finish at their A to E and then wait to be asked those things. And it's just about working out what you like to say and what you're comfortable with, basically, because they will go on to ask you your differentials if you don't give them. So that's how I would answer it. It's not necessarily perfect, but as you can see, it's a big answer. So it takes up a big chunk of your 5 minutes. So this is the important bit, and this is, although it seems like very basic surgical management, it's where you get a lot of your points from. So these are the questions that I got asked. I'm not going to go into the answers because the point of today isn't to go kind of teach you knowledge. But so they asked me, the patient's tender in the right upper quadrant. So usually if they're happy with your A to E and what you've told them, they'll give you a little bit more information. What's your most likely diagnosis? Why do you want to look at the patient's notes? And is there anything particularly you want to look at the op note? So they were getting at whether I want to see if they saw Callow's triangle and if there was any intraoperative complications, basically. And again, they're just checking that you've been exposed to surgery and you know the kind of things to be looking for. Callow's triangle, so they will give you a little bit of anatomy sometimes. Patient continues to deteriorate and becomes unstable. What would you do? The answer at that point is not, I will take them to theatre. It's not, I will take them to ITU. It's, I would escalate to my surgical registrar and possibly get ITU involved to help with her blood pressure. And then what organism would you expect to go on blood cultures, which threw me off a little bit. And I think it's important to know that if your questions start to get harder towards the end of your scenario, it usually means you've done okay and that they've either run out of questions or they're trying to push you to the harder stuff. So don't be put off towards the end if they start asking you stuff that you're a bit thrown off by. So the main points from that scenario is you'll say CRISP, say A to E, and sepsis 6 is a big tick, 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 and don't be put off if the questions get harder. So my second scenario was, you are the orthopaedic SHO on call and are part of the trauma team. You are called to see a 42-year-old male who has been crushed against a brick wall by a reversing forklift truck. They have a heart rate of 110, a respiratory rate of 32, and a BP of 95/60. So you can start trying to think in your mind what kind of avenue they're going down at this point already. You were the first doctor there and are asked to assess the patient. How would you proceed? So I'll give you 20 seconds again just to have a little think about how you'd start this scenario. So again, think about what kind of patient it is, your priorities. So some of you will have been lucky enough to be in a hospital where you've been to trauma calls or seen them. I was in Winchester for my foundation, so any trauma call I saw was an absolute shit show. So speak to Regis, speak to colleagues if you haven't been able to go to those things, and ask for their advice on how you'd start answering the questions. Or look at ATLS brochures if you've got them. Okay, so your priorities for this patient is that this is a trauma patient, so you're going to use ATLS protocol. You could say at this point, I would make sure the trauma team have been called. You could say I would initiate major hemorrhage protocol if you wanted to get that in nice and early. Again, you do your A to E approach. Again, you mention your differentials or what you're worried about, your main investigations, and your bedside management. And those of you who have done ATLS will know that the big thing about ATLS is that you do your A to E, you find a problem, you fix that problem or try and fix that problem, and then you go back to the beginning. So once you've made a intervention, you go back to your A and start again. So it's really important to remember about reassessing as you go along in your trauma patients. So my answer was I would manage this patient using ATLS protocol and an A to E approach. Firstly, I would stabilize the patient's C-spine using triple immobilization. So that should be how all of your trauma patients start. Those of you who've done ATLS will know that you go in using your ATLS walk. So immobilizing the C-spine is your first priority. Then you check the patient's airway and then move on to breathing. I would apply 15 litres oxygen via a non-rebreather and then check saturations and respiratory rate. I would expose the patient's chest, check the trachea was central, and then percuss and auscultate the chest once I was happy with breathing. So at this point, they stopped me and started talking about the problems that I'd found on breathing. If they hadn't stopped me, just because I haven't been able to go into circulation here, one other thing that you would want to talk about in a trauma patient, particularly for circulation, was looking for signs of occult bleeding. So remember, your hidden bleeding for trauma patients is chest, abdomen, pelvis, and long bones. So within your circulation for trauma patients, you would mention, I'd examine the abdomen, look for bruising. I would lightly palpate the pelvis. Don't say squeeze the pelvis, don't say rock the pelvis. And remember that if they have got pain over their pelvis, then you want a pelvic binder on, and then assess the long bones. So that's something that you want to push into your circulation, A to E, basically, for trauma patients. But anyway, so I was stopped at breathing, which they will do quite often in your trauma patients. And they said, okay, the patient is clearly tachypneic and short of breath, and they have SATs of 79%. With this kind of trauma, what would you be concerned about? So they wanted my differentials really early on. How would you differentiate, at which point I talked about tension pneumothorax and hemothorax. How do you differentiate between a tension pneumothorax and a hemothorax? And then what is a massive hemothorax? So things like this come up a lot in the trauma scenarios. And there's certain definitions of things like massive hemothorax that you just need to know. Do you be able to rattle off very easily? How would you manage a tension pneumothorax? So they wanted me to talk about the anatomy of needle decompression and then the anatomy of putting a drain in. And then how would you proceed afterwards? So at that point, I mentioned about reassessing from A to E, and that I would want some imaging of the chest afterwards to check the position of the drain. What other differential would you be concerned about? And the reason I asked that is because I hadn't mentioned cardiac tamponade in my differentials before. So if they re-ask you a question or labour a point, it's usually because you've missed something. So if they say, is there anything else? The answer is usually yes. So have a little think about what you've missed. And then they ask me what the signs of cardiac tamponade were. So I think pneumothorax is a quite common interview question. I think a lot of people get it, or hemothorax. And things like chest drains, you need to be able to tell them exactly how you do them. The vast majority of F2s or SHOs applying for core training have never done a chest drain, but they don't need to know that. You just need to be able to tell them the anatomy and how you do it and how you'd reassess them afterwards. So the main points of trauma patients is ATLS, triple immobilize the C-spine, A to E, I've spelled A, B, C, D, E wrong there, that's good. And then looking for signs of occult bleeding and reassessing the patient. And don't be put off if they interrupt you. They will usually they try and guide you in the right direction. So if they interrupt you or stop you, or it's either because that's their original plan or because you've gone down the wrong route. So let them push you in the right direction. So my main key tips for the clinical scenarios, as I've said, don't be put off if the questions get harder. It's usually a good sign. And don't be put off if they interrupt you. They will try and guide you. They'll try and push you in the right direction. And as Sophie said, they listen to these all day, every day. And they do generally want you to do well. And they want you to get to the end and get to the harder questions. They won't react to your answers, so don't be put off if you're not getting positive feedback or you're not getting smiles and nods or, yeah, you're smashing it, crack on. My interviewers actually turned their cameras off after they'd introduced themselves, so I just had a blank screen to do my spiels to. So don't be put off by that. Practice definitions. So there's quite a few definitions that they will ask you about that you think you know. I'm trying to think of an example. So we all know what a hernia is, but if someone asks you what is the definition of a hernia, it's actually quite difficult to verbalise that in a coherent way. Like, what's a hernia? What's neck crash? What's a tension pneumothorax? We all know what these things are, but when you actually try and verbalise them, it's quite difficult. And then just practice. This isn't something that you can just sit and practice by yourself. Because you need to be able to talk about it out loud and not sound like it's the first time you've ever spoken about it out loud. You also learn a lot from doing it with other people. So I would recommend practicing with a few different people, because sometimes they do things that you really like or word things in a really nice way. Sometimes they'll do things that you really don't like and you think, hope I never say that. But either way, it's a good way to learn from people. And also they're going to ask you questions you haven't thought about. If you're going through scenarios by yourself, you're only going to test yourself on things that you've thought about and things that you probably know the answer to anyway and want to practice saying it out loud. Whereas you practice with someone else, they're going to push you and think of questions that you've never thought about. So yeah, that's the clinical scenario. As I said, I think that's the fun bit. And I think once you get to that point in your interview, it's time to show off. Do revise for it, because it's a huge chunk of your questions, and I was super borderline for my portfolio last year, and it helps a lot by doing well in your interviews. So don't leave it to the last minute. And yeah, find people to practice with. Ask your regs, ask your core trainees, ask your mates. As I said, everyone who cares about you should be bored to death of hearing you say A to E. And yeah. Does anybody have any questions?
I was just going to add on the only thing I would just, Kirsty's mentioned about this, sort of some of the definitions to learn. I'd say also a couple of scoring systems or things as well. So I know sepsis 6 has already come up. Other ones that we've seen commonly come up are the Glasgow score for pancreatitis, the Rockwell score for GI bleeds on the wards, the Wells score for DVT. I think I got asked AKI and the stages of AKI and what that mean, and then third space volume loss with pancreatitis. So I think I got asked both the Glasgow score and the AKI score. And then shock as well is a big one that comes up in the trauma.
Yeah, shock comes up a lot.
So some of those scores are actually really, really important. And actually just being able to rattle off the definition without even thinking about it is really useful, because then on the day you're not just out there like, I think AKI has 3 stages, maybe, not sure, 5 stages, I don't know. And then, at least you know the criteria, and you will feel more comfortable at the end of it from knowing those things.
Yeah, I agree. And it's just the first time you say anything out loud, even though you think you know it in your head, you just sound like a bit of an idiot the first time you verbalise it. So just practice saying things out loud. Someone's asked, do they provide you with information as you go regarding their A to E? So they usually give you the important observations in the little scenario at the beginning. Or if something changes, then they'll interrupt you and tell you. But yeah, they give you the important stuff before you start.
Otherwise,
any question?
I was gonna say, yeah. Otherwise, you just carry on until they tell you something else. I said the other thing as well to make sure in the clinical scenarios is that you make your A to E slick, because you don't want to be spending 8 minutes on your A to E assessment, and then you then are then stuck because you've only got 2 minutes to answer the last few questions. So you need to make sure you can get that A to E assessment done as quickly as you can whilst covering everything, which is why it's another reason to practice it, because if you're spending 10 minutes on your A to E assessment or having got through it, they can't move on to the questions.
They might, so I practiced with a few people that talked as well. And you find sometimes that you're a bit annoyed that you're the interviewer and you can't ask them questions because they're just going on and on and on. So as I said, it's really important just to practice with other people, and everyone will answer questions differently. Some people will give their investigations as they go along in their A to E. Some people will give it all at the end. Some people will wait to be asked. Just find whatever works for you in a way that you won't forget things. And that's nice and slick.
And so I've had another question of, do I recommend any question banks or guides? I think I, at the time, or at similar times, had been revising for part A or part B, part A, when I was doing the interview. So I'd been using, I think, a mixture of PASS test and EMRCS for like the general knowledge questions or anatomy questions. And then question bank wise, I used kind of the standard interview books that I think everyone, yeah, that one. And then I had another one as well.
Was it this one?
Yeah, literally. I was gonna say mine are literally on my bookcase just over there. So if you didn't have them, I was going to grab them.
This one is non-specific for surgery, but it's really good for the management questions and good for your kind of what's a good leader questions. And so the first part of your interview, that one I think is good for clinical scenarios and for the management stations as well. You can get them secondhand quite cheap online. But yeah, I use these two a lot. I think they're quite good.
Yeah, I think the other one's still recommended for use for reg interviews as well. Yeah. So you just never stop using. It's quite a useful one to have long term. And there are other books. There are official, there are lots of courses that you can go on. I didn't particularly want to spend lots of money on it myself, but I know lots of people do, and it depends how you learn and how you work, really. Any other questions, anyone?
Cool. Are we going to send out feedback?
Yes, we will send out a feedback form, and I think we'll put it on probably Facebook and Twitter as well for people to fill out.
Someone's just asked, do they focus on your portfolio? So no, I think they gave a kind of hint before your application started that there was going to be a portfolio station and interview, but they've said there isn't. So it's just 10 minutes management and 10 minutes clinical. That might change for next year if any of you are F1s. So they used to do pre-COVID, you'd have 10 minutes to talk about your portfolio, and then they would judge your evidence then in person. And then you do the management and clinical, but obviously now it's all done online. So once your portfolio is verified and scored, it's done, and you can park that bit.
That doesn't mean that you can't use your portfolio in some leadership and management question answers, though. So if there's something you particularly want to talk about that you think fits in, don't just shove it in. I think sometimes that can be you can kind of squeeze that in there to talk about if there is something particularly impressive that you've done, as long as it's relevant.
Cool. Thank you very much, guys. Thanks for coming. And as we said, we'll send out the feedback forms to you. If you could do that, it'd be really helpful for us.